Jennifer Kennedy, the lead for quality at CHAP, and welcome to this month's CHAPcast. I have the pleasure today to talk with my good friend Kathleen Kerr. Hi, Kathleen. How are you doing?
Hey, Jennifer, I'm good.
Well, can you go ahead and tell us a little bit about yourself, or actually tell our CHAPcast listeners a little bit about yourself?
Sure. I'm a healthcare consultant based in California. My group, Transforming Care Partners, we work with a wide range of organizations with an interest in all things having to do with aging and serious illness care, philanthropies, community-based providers, health systems, payers. Um, Big interest in helping to create sustainable quality programs to get this care that's so needed out to as many people as possible in a way that allows for it to be of benefit to the patients and families that we're delivering it to. I've been in this field in one form or another since 1999.
Wow.
So for a long time. So I've had the pleasure of seeing things shift from wouldn't hospital-based palliative care be neat? And then,
Yeah.
gosh, it seems like we really need some outpatient services too. And then, good grief, shouldn't we be delivering this in the home? And just sort of watching that evolution happen. A lot of the thrill of victory and the agony of defeat moments along that continuum. So that's a little bit about me and what we do at TCP and what our interests are.
Well, you are my go-to palliative care person, and it's been a privilege to work with you, particularly in the last year. We've teamed up on a couple of projects, but when I think about community-based palliative care, I automatically think Kathleen Kerr. So,
Ah.
Kathleen, what's happening in community-based palliative care right now?
Yeah, so much. The the events or the trends that are kind of capturing my attention are continued scaling of community-based palliative care, getting that service available to more patients in more regions of the country. Another big trend is really an increasing focus on getting palliative care to Medicaid enrollees.
Right, right.
California's had a mandate since 2018 that the Medi-Cal, that's our Medicaid managed care plans,
Hmm.
must create access to palliative care, and it's largely home-based palliative care to eligible Medicaid enrollees. So we're into year 5 of that. But they're working on a similar, I think even more expansive benefit in Hawaii. I think in the last 6 months, spoken to folks from, I think 4 states that are sort of moving in
Oh,
that
that's
same
great.
direction. Yeah, I think it's in this time when there's not a federal program, when
Hmm.
CMS or CMMI doesn't have a benefit for Medicare enrollees, there's a recognition that there's a leverage point at the state level, and the state level healthcare has to do with Medicaid. So really pleased to see that. And as a sort of a consequence of this increasingly accessible, more payers of different stripes interested in it, it's really surfaced just even more. These questions have always been there, but even more questions and uncertainties about, well, what services need to be provided to which patients and
Hmm.
by who should be delivering those services. And then how do you assess that? How do you determine if the care is impactful or of quality? And when you look at sort of the landscape nationally, or quite frankly, even within a specific region, you see a ton of variation in those core elements that
Right.
kind of make up a service. The what is provided, by whom, to whom, how is it measured, how is it paid for. So we see scaling, interest in scaling more. And then once you decide to scale, those questions about, well, what do you scale come up? And that's really where a lot of my attention is focused right now.
So that drives me crazy. The variation drives me crazy as a person, entrenched in standards of care and trying to get like care to everyone who needs it. So how should providers and payers really address and look at those questions and uncertainties that are have cropped up, as you mentioned.
Yeah, I think everybody's trying different things, and that's a really big conversation. I think that one of the most useful points to keep in mind, what to hold as the North Star, is the triple aim.
Yeah.
There's a reason why it's hung around for a while and why so many entities have embraced it. It's the simultaneous pursuit of better health outcomes, improved patient experience, and lower per capita costs. And if you keep those three things all together in your mind as what you're striving for, that can really give you some good guidance about how to answer those questions about what to deliver to whom. So keeping that top of mind, I think is truly helpful.
So I love outcomes. And what you mentioned with the triple aim are outcomes, but don't we need at this point um, in palliative care some kind of structure or processes to move things forward?
Yeah, agreement on those. That's right. Outcomes are the product of structures and processes, and that's another, long known fact that we really need to wrestle with, and I think a lot of folks are wrestling with palliative care. We recently wrapped up a demonstration project in California that included 4 payers, 4 health insurance plans, and 11 providers, where we were looking at what happens when you implement contracts that are based on some minimum standards for palliative care. And those were developed by the Coalition for Compassionate Care of California. They're called the California Consensus Standards for Community-Based Palliative Care. Sort of use those in the demonstration project, also the standards for Medi-Cal palliative care that I talked about, and looked at the experience of providers and payers. If you start from these standards, to what extent does that help you in reducing variation? To what extent does that make it easier to deliver quality, sustainable palliative care? And the big lesson that came out of that, which is a little bit of a duh, but it was actually kind of it was good for me to see and remember, is that when you have solid standards, a good set of principles about what should be offered, and you make good implementation choices, how you operationalize those standards, that's what gives you positive outcomes. This demonstration project, we saw, a ton of variation still in how people interpreted the minimum standards, and then also in the extent to which they went beyond the minimums. And so there was expected and unexpected variation, and it really boiled down to, even if you're starting from a minimum set of standards, which do create a good outline for delivering quality care to the right population, you still have a ton of leeway in what you do. Now, this absence of standards, what I think motivated the Coalition for Compassionate Care of California, in partnership with Blue Shield of California, with support from the California Healthcare Foundation, to develop these standards, and then also sort of do a demonstration project to see what happens is when you implement them, is just the incredible negative effects of not having standards, not having nationally agreed to standards.
Yeah,
There's a
yeah.
federal, set of definitions that says this is what hospice care is. This is what home health care is. And many private payers take their cue from what's going on, what CMS asks for. There's none of that for palliative care. And the resulting negative consequences certainly touch patients and families. They don't know what to expect. They don't know what palliative care is. They don't know if the care that they're getting is good. It's hard for them to find it. It's really hard on palliative care providers, because the entities that pay for their services may or may not know what is reasonable to expect from them. It also means that just about anybody can say they're delivering palliative care, and there's no standard to hold them up to say, well, actually, no, you're not. It would be as if you only offered the volunteer component of hospice care, but then said you're delivering hospice. That's not full hospice care, but you have no protection against that in palliative care. And it means that folks that are offering a component of palliative care, which might be helpful, but is kind of insufficient given that what the national guidelines say we should be striving for, they could charge a whole lot less and then undercut those that are offering, a more robust intervention that's aligned with a national consensus guidelines. Not having standards is really hard on payers. They don't know what to write into their contracts. They don't know what to use as a starting point when they're looking to deliver more and better service to their members. And it's also really hard on the other treating clinicians who might refer their patients to palliative care, or how they might react when they hear that one of their patients is getting palliative care. It could mean one thing if one entity delivers it, another thing if another does. They might have an early bad experience with somebody who's delivering just a small part of palliative care. They may not see the value. So this absence of an agreed upon starting point, a degree of minimum standards, is really harmful to just about everybody who's involved in that sort of, healthcare ecosystem. And what you're looking for in standards, or what was existed in the California standards and what exists in the Medi-Cal palliative care benefit, what they're building out for Hawaii and in other places, and what some payers already have in place is, a definition of the population. Who at
Right.
least should be getting these services? And how can we tell that this is the right patient who might benefit? What are those services? What are the minimum elements that need to be there that you want to make sure are delivered? Uh, which providers should be able to deliver this care? What sort of training should they have? How do we know that they're competent? And what are the measures that we should use to determine if this care is having the hoped for impact? And then finally, the standards, as they do with hospice, as they do with home health, as offered through Medicare, there needs to be some language about payment model. You don't use traditional fee for service to pay for hospice. It's an entirely separate benefit. And for palliative care, of course, we know that with the hope that this care is being delivered by an interdisciplinary team, some important members of that team do not have the ability to bill for their services, and so you need an alternative payment model and a structure that allows for delivering longitudinal team-based care in the home over time. Traditional fee for service isn't going to do that. So you need some standards that define that as well. So I think this, getting to the point where we have national standards, or getting more regions or states or big payers to develop standards, or a coalition of folks to agree on standards, feels like a really important next step in helping us to get at the triple aim.
Yeah, I agree with that. And when we're talking about standards, there are a few organizations out there like us, like CHAP, who've developed standards to certify community-based palliative care providers. But how do we know if the standards and the implementation choices are good or the right ones?
Yeah, it's a really good question. Um, this the implementation part of that equation of good standards plus good implementation choices equals good outcomes. The standards tend to tell you what is required, and the implementation choices dictate the how. So
Right.
for example, your standards may say you have to have an interdisciplinary team, but your implementation choices, whether it's the preferences of the payer or the practices of the provider, that says, well, which disciplines of that team focus on which aspects of care? How frequently do they visit patients? Are they allowed to use phone encounters and video encounters, or does it have to be in person? All of those implementation choices contribute to your outcome. It's the complement to the standards. Whether or not they're good implementation choices, and even if they're good standards, I think it's useful to go at it to use two tests. And
Okay.
and the first one is really balance. And it's this idea that the scope of the services that you're providing, which dictates a certain cost of care delivery, that needs to be balanced with the amount of payment that you're receiving as a provider. You can offer the world, but if you're only getting paid for a continent, then you're not going to have a sustainable program. So
Yeah.
you need to balance cost of care delivery with the amount of payment that you're receiving. And then the amount of payment that you're receiving, which is the cost for the payer, that needs to be justified by the outcomes that are achieved. So if the payer is spending a ton of money, think of a very generous payment, they're going to want to see some very good outcomes to justify that.
That seems
Um,
fair. I.
yeah, yeah. So if any one of those gets out of whack, if your cost of care delivery exceeds payment, or if payment exceeds cost of care delivery or isn't justified by the outcomes, once you get that misalignment, you're not going to have quality, and you're not going to have sustainability. And so thinking about balance, that's a really good starting point in deciding if your standards and your implementation choices are good. The next one, this is another, long held set of principles, but I really think thinking about STEEP, the IOM framework for
Hmm.
quality, as you're thinking about how you're operationalizing a set of standards, can be really helpful in deciding, are you offering quality? So STEEP, safe, timely, effective, efficient, equitable, patient centered, really aligns well with what we're trying to do in palliative care. And you can see how those principles align with implementation choices. So safe, do you have the right team members to effectively contribute to, say, medication management if there's opioids involved? Timely, do you have a reliable access to information about what patients need, and the workflows that are flexible enough that allow you to respond to those needs quickly? Effective, are you using evidence-based care? For example, standardized assessments at the time of initial enrollment and then in an ongoing way? Efficient. Are you having everybody practicing at the top of their license? And then also, do you have a flexible approach? Are you allowed to deliver more care to folks who need it then and then titrate down when they stabilize? Are you able to be efficient in your care delivery? Equitable? Do you have intentional efforts to make sure that the entirety of the population that you could serve is represented in the patients that you do serve? And then patient centered, that is at the heart of palliative care. Of course, I think this comes up very frequently in, are you gathering patient reported outcomes? Have you figured out how to get feedback from those people that you're serving, that their experience is what you want it to be? And then are you responding to those findings, adjusting your implementation choices, or even your standards in your contract, so that you can do a better job with that across the different populations that you're serving? So, and then once you adjust things to align with STEEP, you need to go back and look at balance. Did we set the balance off by changing the way that we do things to get at these 6 elements of quality? So using those two set of criteria together, I think, can really serve as a good way of highlighting the extent to which you're offering quality care.
I love the application of that IOM framework because we really don't have, as you mentioned, we don't have a definition, we don't have federal regulations for palliative care. So applying this kind of a framework at least shapes that quality program or quality approach to palliative care for a provider. And I love that, Kathleen. So if
Not
I
my
were to,
idea.
well,
But I'm very
you
pleased to
attached the
use
two
it.
together though.
Yeah.
That's important in the absence of standardization. So if I were to
Yeah.
ask you, what's one thing that a provider could do to improve quality? What would be your response?
Yeah, in addition to those sorts of two sort of touch points that we just talked about, I think something that we hear a lot about now, and it's just so important for us to do, is really to put some focused attention on equity. And
Yeah.
this idea of, are you delivering care, the same standard of quality to folks regardless of socioeconomic status or race or ethnicity or gender, et cetera? And I think a great starting point about that is, do you know? Have you looked at this? And so I think every provider and plan also, or a payer, has the opportunity to first consider their current practices and their ability to gather data about the race and ethnicity and other characteristics of the population that's currently getting community-based palliative care. So that's 1A. And 1B would be, okay, if you have those data and they're reasonably reliable, how does the distribution of race and ethnicity and other characteristics of the patients that you're serving, how does that line up with the demographics in the population overall that you could serve? So are you doing a great job for your white patients, but you're not enrolling any people of color,
Right.
for example? Just knowing that is the starting point for starting to figure out the equity of the care that you're providing. And it's something that those are tasks that I think are within reach of just about any organization.
Yeah, I can't agree with you more because I really have a great interest and focus on health equity, given all of the information that's been made available by CMS. And speaking of the IOM put something out last year as updating the chasm to quality, which came out like something like 2000. But
Yeah,
their white paper that was produced last year identified health equity as the future healthcare quality issue. So
yeah.
thank you for wrapping that in. So Kathleen, I see that we're at end of time. Do you have any last pearls of wisdom to offer our listeners today?
No, I think that's as much wisdom as I have. I think that's plenty for folks to think about, just to, revisit some of the concepts that we talked about. Positive outcomes, good outcomes come from a good model, good standards, and good implementation choices. And good implementation choices can be, that your implementation choices can be assessed by thinking about balance and then also thinking about the extent to which you're achieving steep in the way that you're delivering care. So keeping those ideas in mind, I think will be really useful to folks who have an interest in improving the sustainability and quality of the care that they're delivering.
I can't agree more. Thanks so much, Kathleen, for joining CHAP today to present this really important information about community based palliative care. And thanks to all of you out there in podcast land for taking time out of your day to plug into our CHAPcast. And hopefully, you are taking away at least one kernel of wisdom from today's discussion.